Greetings, everyone, and welcome. My name is Amal Mattu. I work at the University of Maryland School of Medicine, and I want to welcome you to the Emergency Medicine Cardiology Course. We've done this course in the past several years, and we've had anywhere from 1,500 to 2,000 emergency physicians, paramedics, nurse practitioners, nurses, hospitalists, and many other specialists take the course, and we've received really great feedback. This course essentially serves as a boot camp with special focus on emergency electrocardiography. It's 2 days virtual course. Day 1 is largely focused on cardiac ischemia as well as syncope, and day 2 is all about cardiac dysrhythmias, including myths, pearls, and pitfalls, and many of the misconceptions that we've been taught that relate to ACLS in particular. I always tell people, if the sum total of your knowledge of how to take care of patients is based on ACLS, people are going to die. You need to take your skills beyond ACLS and beyond what you learned in medical school and residency, and that's what this course is all about. Let me show you some of the cases that we're going to discuss. Take a look at this. Do you know why this patient who has a left bundle branch block pattern needs immediate cath lab activation? We're going to go through the Sgarbossa criteria and the revised Sgarbossa criteria, and I promise you, you are going to know Sgarbossa criteria better than you ever have before. We'll talk a little bit about Wellens syndrome and also this, which is a mimic of Wellens syndrome. This patient does not have cardiac disease. We'll talk about why this patient, who looks like they have Wellens waves, really doesn't have much of anything at all. We're going to talk about what the drug of choice for this patient with these ugly T waves is in the precordial leads. It's not an ACS drug. So you're going to learn some of the mimics of acute coronary syndrome as well. We're going to talk about some of the non-ST elevation indications for immediate cath lab activation based on the current national and international guidelines. We're going to talk about some subtleties. Take a look at this 12-lead ECG. Do you know what it is on this 12-lead, which the computer read as normal? What is it on this 12-lead, which actually predicts that this patient is about to have ST elevation infarction in the right coronary artery in the inferior leads? We'll talk about that. We'll talk about some mimics of ventricular tachycardia and some indications for when ACLS really is a bad idea. For example, with this wide complex tachycardia, if you use any ACLS drug, including amiodarone on this patient, they're going to die. And actually, that's exactly what happened in this case. We're going to go through a lot of real cases, including a lot of cases that went bad, so you can learn from some of our mistakes. We're going to talk about pacing. This patient has a condition in which pacers will not work. ACLS fails in this particular condition as well. And take a look at this. We'll talk about AV blocks, first degree, second degree, third degree, high grade blocks. A lot of people think this is a Mobitz 2. This is not a Mobitz 2, and pacing is absolutely not indicated. In fact, admission is not indicated for this patient. We'll talk about some tricks to help distinguish between SVT with aberrant conduction versus ventricular tachycardia. We're going to talk about Lewis leads. For those people that haven't learned about Lewis leads, this is a magically simple thing you can do on the 12 lead. Just by repositioning some leads, you can oftentimes make the distinction between VTach versus SVT when you've got wide complex tachycardias. We're going to talk about some mimics of ventricular arrhythmias. For example, take a look at this. Even though the computer is calling this VTach, it's not VTach, and it's totally inappropriate to shock this patient. That's just a little smattering of what we're going to talk about. You're going to get the answers to these cases and a lot more. For 16 hours, we're going to be going through a lot of emergency cardiology in these 2 days, and you're going to know electrocardiography better than you've ever known it before, and the result is that you're going to save lives in the emergency department better than you ever have before. 16 hours might seem like a lot, but the 100% feedback that we get from people is that this course flies by, and you're going to get some long-lasting pearls that will change your practice forever. So check out the website, check out the dates, and I hope to see you all in one of our next courses. Take care.